Here on Game Changers, we're all about helping you stay ahead of pharmacy practice. But why stop at listening? You can earn CE credit for this episode and hundreds more by visiting ceimpact.com and logging into your account or creating a new one. Get credit, get inspired, and make your learning count. Hey CE Impact subscribers, and welcome to the Game Changers Clinical Conversations podcast. I'm your host, Rachel Maynard, and I'm excited to dive into our discussion today. And today we're going to be looking at the management of fibromyalgia, a chronic condition that causes widespread pain all over the body and affects millions of people in the US. But treatment for fibromyalgia can be challenging because there's no one cause, and symptoms can be very different from person to person. And there are a couple of drugs that are approved for fibromyalgia, but it's been over 15 years since any new treatments have become available. And now another new option was recently approved, but we'll see that it's not actually a new drug or active ingredient. It's actually a drug that's been on the market for decades, but now in a new formulation, strength, and approved for a new indication. And so with that, I'll keep you on the edge of your seats for a minute, and our guest today will help us figure out where this new option fits in for managing fibromyalgia. And I'm thrilled to welcome our guest to speak about this topic today, Dr. Mandy Mullins. So welcome, Mandy. We're so excited to have you.
Hi, thanks so much, Rachel. I'm excited to be here.
Fantastic. So, Mandy, maybe you can share a little bit about your background for our listeners to get to know you a little bit and your role, your current role, how you got into that position, and what made you interested in this topic.
Absolutely. So, as you said, my name is Mandy Mullins. I am a pain pharmacist by training, so I did specialize in pain management and palliative care. I currently work as a pain management and opioid safety coordinator at the VA Medical Center in Marion, Illinois. And within that comes a lot of different roles. A lot of them are more administration based. However, I do still have clinics, and that is obviously targeting, our veterans in chronic pain. So I do see a lot of fibromyalgia in my daily workflow.
That's great. So we'll have some real life experiences, hopefully, to hear from you on that.
Absolutely.
Again, thank you so much for your time and for joining us. And I think it would just be helpful to sort of lay the groundwork so we're all on the same page and maybe just give us a brief overview of what fibromyalgia is and what kinds of symptoms people have, and then we can sort of think about how it's managed. But let's start with just that overview first.
Sure. So, fibromyalgia really is one of the more difficult to explain and difficult to understand chronic pain conditions, really because it's something that we can't see, so there's
Mm,
no physical component to fibromyalgia that is causing, the issues and the symptoms that we do experience. And so, it is characterized by chronic pain, but also sleep issues, chronic fatigue, things of that nature that, again, are both adding or can add to that chronic pain element, but then are also very invasive in people's lives as their own symptoms. So imagine not sleeping well daily or nightly, and having chronic pain on top of that. So it's kind of a vicious cycle of
yeah.
what do we target first, and that depends on that person specifically.
Yeah, and I like how you said there's no there's no like markers that we can look for, no blood tests that can be done or imaging that can be done to identify it. It is sort of a nebulous diagnosis based on symptoms, really. Would you say that's a good characterization or
100%.
yeah,
And if you look at the history of even diagnosing fibromyalgia, it took a long time for providers to agree that it was even a real condition, because there's not something that says yes, you have this. So it is
right.
often referred to as a diagnosis of exclusion. But more and more, as times are changing and as we're getting better at recognizing fibromyalgia, it is becoming more common because we kind of know what to look for.
And how often would you say that there is overlap with other conditions like depression, anxiety, other sorts of, even like I guess is it autoimmune related, or is it commonly co-occurring with autoimmune conditions?
I would say definitely co-occurring. And then you have some other conditions that kind of, I don't know, should make your spidey senses go off a little bit. If they have that diagnosis, then fibromyalgia might also be there, kind of hiding, within those different symptoms. So things like chronic fatigue would
Hmm.
be one, especially in women, because fibromyalgia is more prevalent in women. The minute that you hear chronic fatigue, something should kind of just, tickle your senses a little bit. Like maybe I should be looking also for fibromyalgia or thinking
Hmm.
about fibromyalgia in that specific person. Um, so like a chronic fatigue picture, plus they have, this chronic pain that doesn't really have a source. You're kind of then thinking, wait a minute, we should evaluate this.
Hmm. Okay. And in terms of management, are there guidelines available for treating managing fibromyalgia? And if where do you start in terms of thinking about management? Again, because it's such a multi-symptom sort of condition that's hard to really pinpoint. How do
Mhm.
you start when thinking about management?
Yeah, it's a great question. Typically, I'm going to see what's most bothersome to that person. So if
Okay.
they have that diagnosis of fibromyalgia and they come in and they say, for example, my pain is out of this world, and they don't have quite as much of, the sleep issues, um, other symptoms, then, maybe we'll do our best to treat that pain as much as possible first and then address the other symptoms later on. However, if someone comes in with you know chief or their chief complaint is sleep issues, then you might target that first and hope that the pain kind of follows
Hmm.
suit, with once you get the sleep a little bit better controlled. But there are guidelines. So this is really fallen to the rheumatology side, to kind of manage and update those guidelines. And, that goes back into really the history of fibromyalgia and back when it, was first becoming more prevalent or more accepted as a diagnosis, no one was really claiming it because we didn't know where
Mm.
it fell, because we didn't
Hmm.
have something to look at and say, this is the cause of this
Hmm.
condition. So it kind of fell into the rheumatology world. And so they still, the American College of Rheumatology still kind of, updates that and owns that along with the European Society.
Okay. Okay. Interesting. Yeah, it's tough when it's such a murky sort of, yeah, like you say,
Mhm.
diagnosis, and then nobody, there, nobody
Nobody
wants
really
to. Oh,
wanted it. Yeah,
yeah, yeah, it's unfortunate,
it is.
obviously. So, but yeah, and so in terms of, so say you have a patient who's sort of with that classic, with the characteristic of widespread pain. Where do you typically start with managing that widespread pain, or what are your first steps if that was your area of focus?
Absolutely. So you're looking at things that, are previously approved for fibromyalgia specifically. So that includes duloxetine, pregabalin, and then we also have milnacipran, which is still brand name. But those are, our three that are approved. Now, of course, we stray away from that often with the management of fibromyalgia. But really, you're looking at, okay, well, which one's best for this person? So just having even, that those couple of medications that we do use, it's still going to vary which one you're trying first in an individual based on, what other medications are they on already? What's their past medical history? Is something contraindicated at this point that I can't even think about? So it really does just depend,
Hmm.
which is, the unfortunate reality of really anything in chronic pain management, is that it's going to be different for everybody.
Right. And how about non-pharmacologic treatments too? Because it seems like that is a core component of managing this condition too. Would you agree with that? And if so, what sort of
Yes,
places do you start
yes.
with for
So
non-pharm?
absolutely. And yes, actually, the number one recommendation for fibromyalgia is actually exercise. So exercise is what has been found to be the most beneficial in reducing pain levels, improving sleep, improving the symptoms of fibromyalgia. The problem with recommending exercise is that a lot of, those individuals with fibromyalgia it's just not happening, right? It's not
Yeah.
doable for some
Yeah.
reason or another. And so then that is when we do kind of resort to the medications.
Yeah. Or at least to help provide some relief, perhaps to then get them started more m- more
Yes, so that
focused.
they can get up and
Exactly.
exercise. Yes,
Exactly. Yeah.
exactly.
Yeah, that's the
Hmm.
challenge. And again, it's sort of this vicious cycle, chicken and egg situation where how are you going to start exercising if you don't feel well enough to move? And, providing some sort of relief is hopefully where we're
Hmm.
going with some of these treatments. And so you mentioned duloxetine and
Hmm.
milnacipran, which I are both the SNRIs, so working in that sort of on neurotransmitters, I guess, is the way that they're working to provide some benefit. And pregabalin, you said, was the third. So maybe in terms of how
Hmm.
those are thought to work for those symptoms, and then we'll talk about the new drug that was recently approved. But maybe just putting those in perspective in terms of their mechanism and how that ties into the potential benefit that we would see.
Yeah, yeah, sure. So, that could be a really, really long, in-depth answer, but I will try try to make this try to make this as short and sweet as possible. But so you have things like duloxetine and milnacipran, like you said, that are classified as SNRIs, which stands for our serotonin norepinephrine reuptake inhibitors. Those, when you're looking at the pain pathway specifically, so from the minute that something goes wrong in our body to our brain's response to that, all of that in the pain pathway, you will see both serotonin and norepinephrine involved in that process. And so, the easiest, way to think about it is serotonin and norepinephrine are a lot of our or some of our feel good
Hmm.
neurotransmitters.
Hmm.
And so by increasing that in our body is going to help then decrease our pain signaling. And
Okay.
so that is, again, one of the ways that those
Yeah.
are working to decrease our pain levels. Pregabalin specifically is working and has a part in that pain pathway. So a lot of the same end goals, but they're going about it differently through different
Okay.
pathways.
Okay. Okay. Well, that's a helpful overview. And again, complex condition, complex sort of treatments and how they might fit in. But I will sort of get to the punchline, which is the fact that we have this new drug, again, first drug available approved for fibromyalgia specifically in over a decade. And it is cyclobenzaprine sublingual tablets. The brand name is Tomaya. And when we think about cyclobenzaprine, what has been the role of cyclobenzaprine to date for fibromyalgia, and then what is sort of different about the sublingual formulation, and what advantage is that supposed to provide, if any, and sort of helping us understand the role of that drug in general for fibromyalgia.
Sure. So, cyclobenzaprine has been like around for a long time, in its, oral form, in the tablet form. So when thinking about fibromyalgia, there are situations where cyclobenzaprine is used, and it can be used quite effectively, even in like that oral tablet form, mainly when thinking about like sleep issues. One of the main complaints of cyclobenzaprine as a muscle relaxant itself is that it's causing too much drowsiness, and folks
Hmm.
can't take it during the day because, they can't tolerate it because of the sleep. And so, really in fibromyalgia, we're using that then just to our advantage. So we're using
Okay.
that side effect to hopefully help with any sleep concerns, that somebody might be having with fibromyalgia, and giving that to them. One of the issues with the oral form, again, that was already approved, is really, again, just the sleep issues. Sometimes the doses, we can't really go as low maybe as we want to with some of those doses, um, for tolerability concerns. So I think, this new sublingual option, which is lower doses than what is already available in the tablet form, it could hold a place in fibromyalgia treatment. Um, we're gonna have to see. It's exciting.
Yeah.
It is
Yeah.
exciting to have a
Yeah.
new option.
And of course, there is always, the initial studies that brought it to approval, and then, yeah, seeing what's actually happening in real world practice and how it plays out in patients who are taking it. And then also the question about long-term safety too. We learn as we go in some cases. Obviously, we have a lot of data with cyclobenzaprine oral tablets, but in terms of the new formulation, we'll have to see risks and benefits there. So, but specifically that sublingual form, is there any difference in terms of what patients like in the onset of effect or duration or anything like that that would make that a distinction from the oral tablets? What could we learn from there? Um,
Yeah, absolutely. So, I looked at the trials that got it approved. They did find, that the onset was a lot faster than the oral tablet, which makes sense. It's a sublingual product.
mhm,
It's getting into our system a lot quicker, than swallowing a pill and letting it go through that
mhm,
process. So
mhm,
it is getting into the system quicker, which means it is going to have that quicker onset, which again is good. If you're using it, in this case, like for fibromyalgia, for sleep,
mhm,
then it
mhm,
is good,
mhm,
because we want that to come on, so that we're not having to predict, okay, how long do we think that this is going to take, to kick in? What time of day do we take it so that,
mhm,
we're
mhm.
timing it appropriately? So that is helpful, that it is that route of administration, and that,
Gotcha.
it's a little bit more predictable for us.
And as you say, it sounds like it's primarily helping with the sleep component
Mhm.
and supporting better sleep. And so it is something that's taken at bedtime before sleep. And so, again, hopefully would have the effect to support sleep after being taken. And again, hopefully a little bit different onset, perhaps.
Yes.
Um, so in terms of the studies that brought it to market and allowed us to see, what kinds of benefits are we seeing, and was the benefit primarily in sleep, or did we see any difference in pain, or what if you could describe those studies a little bit to help us understand where it's
Sure.
going?
So they were all slightly different and found slightly different things. So sleep was kind of, like the unanimous, yes, we found improvements in sleep, which is kind of as to be expected,
Yep.
just based
Yep.
on cyclobenzaprine itself. Um, where the studies started to differ a little bit was actually in their benefit on actual pain levels or the pain scores. So one study found a statistically significant improvement in pain levels. Um, what's interesting, the global impression of change, the patient global impression of change, excuse me, which is just a one question tool that is used to assess how much that person feels like they have improved. So, um, it tells you kind of where their mindset is at a little bit more. And that did not improve in one of the trials, which was interesting because even with, some benefits in the other symptoms, they
Mhm.
were still feeling like, I'm not sure that I'm any better.
Yeah.
Yeah, so a little bit interesting there. But overall, the sleep looked good, from what those trials were saying. So I think, time will tell.
Hmm.
It's tricky
Hmm.
because fibromyalgia is also something that, comes on stronger and then gets better and then comes
Okay.
back, a little bit stronger. So it waxes and wanes a little bit.
Okay.
Just naturally. So it's really just hard to tell, especially in, like the clinical trials that are maybe only following somebody for 12
Right.
weeks,
Right.
what is actually the bigger picture of this?
And to get to that, so as you said, if these trials are relatively short term, do we have any longer term data, or we just have to sort of wait and see how once it's out in the wild, what we're gonna how
I
okay.
think we're
Okay.
gonna have to get it out in the wild and see how it does. Yeah.
So and that is another consideration because not only is it a question of safety or efficacy after those 12 weeks, but also safety considerations and what that might pan out to be because most
Hmm.
people historically, I don't think of cyclobenzaprine as something you would take long term necessarily. Maybe for fibromyalgia, we do have some experience with it in a longer term setting. What's been your experience with that?
Yes. So, in the chronic pain world, we are told not to use a lot of things long term, and we
Yep.
end up using them long term,
Right, right,
because that's just the nature of the beast, I guess. Because chronic pain is not going away. So it you need that treatment for it. So if it
Mhm.
says not to use it long term, or I believe most, if not all, of your muscle relaxants as a category or as a class actually say do not use for longer than 7 to anywhere to 14 days. And it's like, well, we
Yeah,
are.
right,
And so
right.
we continue to monitor, make sure
Yeah,
that they are tolerating it okay, make sure that, we're not adding anything else on board that can, contribute to some additive side
right.
effects or things like that. Um, so yes, time will tell how it does,
Yeah.
again, like you said, in the wild, in real life circumstances, but it is nice to have that option because
Yeah,
the dosing for the sublingual cyclobenzaprine is lower than our tablets, like we said. So with that, I'm hopeful that it will be better tolerated long term, because
okay.
it's not something that I see being started and then stopped.
Right, right. And even in the labeling, and just to, say what the dose is, it's a
Mhm.
2.8 milligram tablet, sublingual tablet. And I think patients start out with just one tablet once a
Mhm.
day for 2 weeks at bedtime, and then go up to the two tablets once a day at bedtime is that
Right.
target dose. And then
Yes.
again, yeah, nothing in the labeling that I saw about like how any duration specified. So it is something we might see patients on longer term potentially if it is supporting, helping with their
Hmm.
symptoms.
Absolutely.
Um, so it is that bedtime medicine. But we talked a little about the mechanism of those other approved drugs. Let's
Mhm.
just briefly touch on how this drug also helps. You mentioned sleep and the sedative effect, but is there any other sort of is there any effect on serotonin, norepinephrine with cyclobenzaprine, or any other sort of mechanistic effects that we might think could be helpful?
Yeah, so cyclobenzaprine for fibromyalgia, really cyclobenzaprine as a whole. We have some guesses of how it's working, but and not to go too broad, but a lot of our muscle relaxants, just in general, we're like, okay, well, we think it does this, but
Yeah.
we don't really 100% know for sure. But cyclobenzaprine, we know, has like some centrally acting effects. So it's working on our brainstem to do a couple of different things. Obviously, one of those side effects is the drowsiness. But it does have some like serotonin involvement or effects. It also has some like adrenergic, you know, it works on a myriad of of different receptor. I mean, it does like so many little different things, that it's really kind of hard to conceptualize sometimes because you're like it's all just so intertwined. But
Yeah.
it does have some serotonin involvement. Um, yes.
Yeah.
So benefit usually when we think of it in like pain management or chronic pain, usually you're actually thinking about like the actual like muscle activity that it has, as hence it being a muscle relaxant. And so most often, you're seeing it used for other painful conditions that are actually involving your muscles. Whereas fibromyalgia is going to be more of like those background pathways, like the serotonin
Hmm.
involvement, maybe some brainstem involvement, in reducing like that pain signaling.
Gotcha. Okay, so, and I think that's actually a really important point because one of the considerations and warnings in the labeling is around concomitant use with other serotonergic drugs. And I would imagine, based on what we talked about before, in terms of the common treatments for fibromyalgia, that many patients might also be, even not for fibromyalgia, but for these comorbid conditions,
Mm-hmm.
they may be on other medications that have serotonergic effects. So, how would you like say that interaction? It seems likely like it would pop up in a
Mm-hmm.
pharmacy software system. So, how do you address that? What is your thought process if a patient gets this new prescription for cyclobenzaprine and then is already on an SSRI or SNRI for any other reason?
Mhm.
What is the significance of that warning?
Yes, so I can tell you that happens all the time, right?
Yep.
We get the serotonin syndrome warning
Yep.
probably more than, anything
Yeah.
else.
Yeah.
Because, again, in chronic pain, a lot of our medications, because we're trying to influence that pain pathway, are, interfering with serotonin in some way, shape, or form. So we do get that a lot. And it's one of those things where you do have different kind of incidence rates with different medications on,
Mhm.
are they likely to cause a serotonin syndrome, or is it more of a it can, but usually we don't see it. And so I would say cyclobenzaprine is in that, it theoretically can, but we don't see it super often category. So,
Okay.
if I got that warning with like cyclobenzaprine and like duloxetine, for example, because that's another very, very common one, I'm going to give it some thought. I'm going to have that discussion, with that person that we're starting on it, and just educate them, on the signs and symptoms of serotonin syndrome. Stop probably the cyclobenzaprine, immediately if you do experience those symptoms. But overall, it's not something that I'm going to actually expect to happen very
Mhm.
often.
Mhm.
But, even saying that, it's something that you definitely want to make sure that they're aware of, because, if they're not and it happens, then that's a problem.
Well, and it's one of those things that there could be some other factor that then tips them over into that higher risk category, especially if they get any other medication added on, and maybe
Hmm.
they've been stable on a couple
Hmm.
of medications, like you said, duloxetine and cyclobenzaprine. If they've been stable and then another serotonergic med is added on, then it sort of increases that risk. So absolutely making sure that patients are aware of some of the most would you, in terms of counseling, would you focus on a few specific sort of symptoms that they should be watching for and alert their provider
Yeah,
to? Or
the ones that I typically educate on are like irritability, or like, snappiness, right? Because a
Mhm.
lot of the times if someone has a spouse, they're some of the best like information givers about that
Mhm.
person, sometimes over what they think. They're like, no,
Mhm.
you have been like, snappier lately, or you've been, more
Mhm.
irritable, things of that nature. So irritability is one that I like to watch for. Just like some sweatiness, clamminess,
Mhm.
like generally just not feeling well and like feeling
Mhm.
off.
Mhm.
Sometimes just, telling them to be mindful of that, is
Mhm.
enough, because that kind of like encompasses a lot of your like signs and symptoms of serotonin syndrome, is just that general feeling of something's
Yeah.
not right. And,
Yep.
you're sweating and, you can't figure it out, and you're kind of, your mind's racing. And like that's the perfect, situation or example of like one of the some of those first steps in that
Yeah.
process.
Yeah. And so educating, and again, that alert will probably pop up every single time you dispense those medications together. So,
Hmm.
counseling them upfront when they're receiving that, but also taking that opportunity, I think, as they show up for any refills to remind them, hey, if you ever are
Hmm.
feeling off or feeling
Yeah.
sweaty or jittery or,
Yeah.
tremors at all, those kinds of things, just report those right away. And, it doesn't necessarily mean you have serotonin syndrome or that's happening, but just to be aware of some of those things to be watching
Right.
for. And
Exactly.
so we sort of transitioned into some of the counseling points, and I think that makes perfect sense because there are some unique considerations with this drug. I think another one is that CNS depression, which again makes sense given how we're sort of looking for that as a potential benefit in
Hmm.
helping with sleep. But what should patients know in terms of that potential side effect and how to manage that or prevent it?
Yes, that's a great question, because, especially where we're at. in our current climate right now, with pain management and the opioids and everything that's going on, there has been some evidence that has come out that opioids in combination with muscle relaxants, so things like cyclobenzaprine, can, increase that risk of respiratory depression, which we don't want. Opioids typically are not recommended for fibromyalgia treatment. However, fibromyalgia, kind of like we talked about earlier, comes with so many different symptoms that
Mm-hmm.
sometimes opioids are prescribed.
Mm-hmm.
And sometimes that's the only thing that they have found that is actually helping with their pain up until this point. And so it is a situation that I can almost guarantee that, we will run into, is that
Mm-hmm.
somebody is getting this cyclobenzaprine on top of opioids, main or possibly other stuff, that can cause CNS depression. So in that case, just educating on feeling overly tired. So not just like
Mm-hmm.
the normal, I can snap out of this and go about my day, but like unable to continue on. That level of drowsiness is a concern. Um, falling, falling, obviously a concern, but that hints at something that is more than just like the drowsiness side effect of
Mm-hmm.
cyclobenzaprine, if that makes sense. So
Mm-hmm.
kind of giving some of those real life examples really helps. I think people picture like what exactly, where that line is drawn, what's concerning versus what's expected. And so in that case, always asking for a naloxone prescription is a good idea if you're on that
Mm-hmm.
opioid in
Mm-hmm.
addition to the cyclobenzaprine. But other than that, it's just a lot of education on, like I said, where is that line from this is a good option to help us sleep to, okay, something's not right.
Well, and I think also having patients take stock of where their baseline is, as you said. So
Mhm.
knowing sort of before starting any new medications, taking stock, maybe even jotting down, the severity of their symptoms and how they feel at that time before they start. And that not only can help
Mhm.
them understand if they're having potential side effects, but also any potential benefit that they might or might not be seeing from any
Absolutely. Yeah,
medication. It's really,
absolutely. That's a great point because it is, it's all about the change. And
yes,
so, yeah,
yeah,
in either direction, good or bad, we want to know,
yeah.
we want to know what's improved, what's not improved or what's got worse because we want to fix it.
And that seems like such an important point, in particular with fibromyalgia, just because it is hard to quantify in any other way. And so, really, sort of having those patient assessments,
Hmm.
self-assessments, seems like a really important thing for them to be aware of and for them to be doing. Alcohol is another consideration, obviously, for the same
Yes.
reason. And so,
Yes.
again, if you say a person is thinking about having a holiday drink, how would you handle that situation? And again, is it just education, just
Yeah.
making them aware of the risk, and again, sort of that tipping the balance potentially with a few concomitant things happening. What is your typical approach for that?
Yes. The best answer is to say, well, just don't do it. Right. Don't have the holiday drink.
Yeah,
But,
yeah,
is that realistic? And
right,
that's where you get
right.
into, okay, where are we going to find some common ground? Because,
Yeah,
you know, if somebody wants a holiday drink, at what point does your quality of life,
right, right,
take
right,
over versus like what
right.
medications you're taking? And, it's just something to consider. But, I have found that most of these people, right, they know their bodies in a
Yeah,
sense that
yeah,
they know that they can have a beer or a glass of wine or like a
yeah,
festive drink and then call it after that.
yeah,
And not have any issues. And so I'd say a lot of, talking about like history about, okay, well, like, do you know where that point is to where,
yeah,
we should say no more? And if they do, and you have that good relationship with them, and you can have those open and honest conversations, then really, I mean, that's all you have to go off of, right?
right,
Because
right.
you can tell them don't have that drink, but then if they're just going to turn around and have that drink, I'd much rather have the conversation of, okay, well, let's figure out how many, can we have one or two drinks and then call it after that and kind of find like a,
Yeah,
you know, a shared decision-making approach, basically,
Right.
to find like that answer of, okay, what are we going to do in those situations?
Exactly. And
Yeah.
this is like the recurring theme I'm hearing from our conversation is this individualization and very personalized conversations. That shared decision making, I think, is so important with some of the considerations in terms of safety and interactions that we've been talking about. And another one too is, I think in the label it says about not driving or doing any, that standard language about not driving or doing anything that requires concentration
Right.
until you know how this affects you. And again, it's a very, like you say, patients know their bodies. So
Mm-hmm.
making them aware of that, but also having them understand, this is a risk, but if you're aware of how what your baseline is and whether that changes, you're going to have the information needed to know how to go forward. So
For
yeah,
sure.
definitely some challenging considerations there that I think will come up with when talking with these patients. And so to sort of wrap up the sort of management of fibromyalgia and this drug in particular, considerations with that, let's talk about some of those other specific counseling points that are really important with this drug and maybe what's unique about it too. So that sublingual formulation, I think it has some unique considerations just by the fact that it's sublingual. So
Mhm.
maybe you can talk about a few of those points that we want, especially, pharmacists have never seen this drug and not dispensed it. What will be those key things that we should be reminding patients about?
Absolutely. I think, first and foremost is that it's not to be swallowed, right? So anything
Yep, yep,
sublingual, don't swallow it, right? It's
right,
not meant to work that way. It is formulated different. It is not equal to a tablet. So,
right.
if you've never had a sublingual medication before, it is different, right? Because you have to give it time and, you can't just swallow it with a glass of water. So,
Yeah,
actually counseling on the administration, I think is probably the most important thing in this case, since it is different. And since honestly, many of these patients with fibromyalgia that may be started on this probably have taken cyclobenzaprine in the
right. I was
past,
thinking that. Yeah,
and so
yeah.
just kind of educating on the differences. Again, namely sublingual. So stick it under the tongue, let it dissolve, let it, do its thing. And then, aside from that, I think just educating on this is going to hit you faster than
Hmm.
what like that PO tablet was going to do. So, don't take it at dinner time.
Hmm.
Wait
Hmm.
until
Take
you're
it at
actually
bedtime. At
right.
bedtime.
Wait
Yeah.
until you're
Yep.
actually going to bed
Yep.
before you take this because it is going to, like I said, that onset is going to be a lot quicker because with that sublingual route, it is getting into our system much, much faster. And then, of course, educating on the drowsiness and why that may be helpful, and the fact that that is what we want because, as we all know, right, a good night's sleep can do a world of
Hmm.
wonder for
Hmm. Hmm.
a lot of our other symptoms.
Yeah. And again, thinking about that vicious cycle and trying to nip that in the bud a bit
Hmm.
with helping
Hmm.
with sleep. Yeah, and I think it's helpful because it's taken at bedtime. So some of those considerations, like there's a comment in the labeling about not eating or drinking for at least 15 minutes and not having any hot, cold, or acidic beverages until the morning after. And I thought
Yeah.
that was interesting, sort of thinking about it similar to I think like nicotine replacement therapy has the same
Yes.
sort of warning.
Yes.
And
Yes.
so, that might not be something patients think about at all. And so letting them know this is why it's taken at bedtime partially so that you just go to bed and you don't have to think about
Hmm.
consuming anything else that might affect how that drug is being absorbed. But also tying that back to some of the other side effects that patients may see, I think like some tingling or numbness, some of those sorts of
Yes.
side effects are quite
Yes.
common. Maybe you can speak to
Yes.
that a little bit.
Absolutely. So, with the sublingual, route of administration, since it is formulated differently, we are going to have different chances or risks of some of like, what we would call like those local side effects, right? It's
Hmm.
like when you get an injection of, your flu shot, whatever it may be, the number one concern or side effect possibility is like that injection site reaction. It's
Hmm.
kind of the same
Yep. Yeah.
concept,
Yeah. That's a
right?
great
It's
analogy.
it's
Yeah.
it's kind it's the same concept that what at the site of action there might be some of what you just said, kind of like the tingling in your mouth. it can happen. And it did happen, in the studies that got it approved. So it's not going to be a huge surprise if that continues to happen as
Mm-hmm.
we use it in
Mm-hmm.
real world scenarios. So I think that one, I also saw some dry mouth
Mm-hmm.
potential.
Mm-hmm.
Um, so yeah, a lot of like different mouth things. Now, is that reason to stop taking it? Not necessarily, not unless it becomes, so overbearingly painful or, you can't, your mouth doesn't go back to, getting some saliva, then maybe that is something that we need to consider and,
Mm-hmm.
try to figure out. But, um, most of them are going to be tolerable.
Yeah. Yeah. And same. I love that analogy of the injection site reactions because they're tolerable, go away and not necessarily something that's going to prevent you from getting an
Right.
injection.
Right.
And I think, one thing it looked like the labeling was suggested having the mouth be moist, so having a few sips of
Hmm.
water before taking. So if a
Hmm.
patient is complaining about some of those oral symptoms, there are some strategies that we can suggest to help manage those. And like you say,
Hmm.
just being aware of that. And if that's happening, maybe there's something with the administration we can help
Yep.
them through. The other thing I think is worth mentioning in terms of the counseling points and awareness, especially because you did mention that fibromyalgia is more prevalent in women, is the pregnancy considerations and
Hmm.
warnings around this drug. And I don't know that they're necessarily different than what we might have seen with cyclobenzaprine originally, but the labeling is quite specific in terms of making sure patients have a pregnancy test before they start this and
Yes.
that they're using contraception. So, where is that coming from? And help us understand what to tell patients there.
Yeah, absolutely. So cyclobenzaprine itself, so whether sublingual or not sublingual, or oral, is not recommended in pregnancy because it can cause, I believe it was like neural tube defects. So
Okay,
not something that we want to take if we are, trying to get pregnant already. So yes, a pregnancy test would be a good idea if that's needed, unless, unless we're postmenopausal, have
sure,
something else that would obviously not
sure.
allow us to get pregnant. But yes, something
Yeah.
definitely to be considered.
Yep. Yeah, I just thought it was interesting to see that specific recommendation about making sure if you can't get pregnant that you're on birth control and at least throughout the course of treatment, I think for 2 weeks afterwards as well after stopping it. So important consideration again for a
Yep.
lot of this population. All right, so just for the sake of time, I
Hmm.
think we'll start thinking about one question that I think might come up is say you do get a prescription for the sublingual formulation and it's not covered, which we
Hmm.
know can be common with new drugs, especially that are brand name only. Is there what would you do in that situation? And say, we'll try for the prior authorization if that's something that the insurance is requiring, but if that doesn't go through, would you think about off-label use then of cyclobenzaprine as an alternative? And you mentioned that it has been used historically, and
Hmm.
so how would you help navigate that situation?
Yeah, that's a great question. And that's something that I do see happening because, like you said, people are always trying to find ways around, okay, what can you do that's similar to this until we
Right,
can get this one, the way that we want it, right?
right.
So it's a great question. I think, if I were in that situation, I would, if I thought that cyclobenzaprine sublingual was going to help them, I would go for it because why not? Right.
Hmm.
You do have to kind of make your case. So like, why
Hmm.
aren't, some
Hmm.
of the other options that
Hmm.
are approved for fibromyalgia being used, whether that be contraindications, failure of that therapy already, whatever it may be. But yeah, I think, I would go for it. And if it is turned down, mainly because of price at this point is what's probably going to be the
Hmm.
issue, then I think, given the oral cyclobenzaprine consideration isn't a bad option. Like we kind of talked about earlier, it is going to take a little bit more of the educated guess work
Hmm.
to, get the dose right, get the timing right, get the
Hmm.
administration right. To whereas, this one is going to eliminate a lot of that. Okay, what time do we need to take it?
Hmm. Hmm.
Do we take it with
Hmm.
dinner? How quickly is it going to affect you?
Hmm.
Those different questions. So, it's not something that probably can't be worked around, but it would be more difficult for sure.
Yeah. Yeah. And it's definitely not a one-to-one conversion because they're
Right.
different strength altogether. 2.8 milligrams versus the lowest strength of the tablets is 5 milligrams of the oral
Mhm.
tablets. So,
Mhm.
yeah, it would take some discussion with, the prescriber and, or, the other clinicians working with the patient to make sure that they're getting the intended effect if they are going to be
Absolutely.
switching. Yep. All right. Well, bottom line, what would you tell, me as a colleague? And I'm like, what is this new drug and where is it going to fit into managing fibromyalgia? What would you be your 30-second bottom line?
Oh gosh, I think, I would say if your primary concern is some sleep issues, then this would be a good place to potentially start. Because really none of the other ones that we use or that are approved for, I'll say approved for fibromyalgia, really target the sleep aspect, right? Most of them are targeting like the actual chronic painful condition
Hmm.
part.
Hmm.
So if you have something on board that pain is not their primary complaint and really sleep is, then this would be kind of the route that I would go down in that scenario. Um, yeah, I think I would just tell you to focus on whatever symptom is most concerning to that
Right,
person at that time.
right. Okay, great. And it goes back to that point about individualizing and personalized care and shared decision making, all of those good things.
Yes.
Um, And so, are there any other game changers outside of that bottom line? Any other game changers that you'd want people to walk away with on this discussion? And
I think I would just again reiterate the bottom line is that
okay.
what you think might be most important to somebody, it might not be what they think is most important, especially with fibromyalgia that has so many different symptoms that, present at different times. And realizing that, one visit somebody might be concerned about sleep, the next visit they might not be. And that is very normal and, just something that we have to balance and getting them a better quality of life.
I love that. Yeah, and that goes back to the idea not only of symptoms can change, personal focus can change,
Hmm.
but also the waxing and waning that can happen too. And so, yeah, empowering patients, I think, with the tools they need to be able to monitor themselves and help us help them get resolution for some of that.
Yeah,
Yeah.
for sure.
Okay. All right. Well, thank you so much, Mandy. This was a great discussion and definitely learned a lot about this this new product and where it might fit in. So thank you so much. Really appreciate your time.
Yeah, it was fun. Thank you so much for having me.
Excellent. All right. Well, listeners, be sure to claim your CE credit for this episode of Game Changers by logging in at ceimpact.com. And as always, have a great week and keep learning. I can't wait to dig into another game-changing topic with you all next week.